Yes, we got it.
Okay, very good.
Yes.
All right, good. So let me show you this one. This is a patient that had a very complicated and difficult surgery for a mediastinal mass. This mass that you see there turned out to be a thymic carcinoma, but it was difficult surgery in terms of resecting it because it involved the phrenic nerve, which they knew and expected, but it also involved a portion of the left upper lobe, and in order to get it out, they had to basically resect portions of the left upper lobe. So a difficult operation, and here is post-op day 1, or the first one that we have, and you can see there is opacity in the left upper lobe. We have chest drainage tubes and clips, everything we expect to see. And I speculate, but I can't quite remember whether they attended to the left hemidiaphragm and did a plication procedure after sacrificing the phrenic nerve. So here is an image done 2 days later, and it still shows opacity in the left upper lobe, perhaps a little bit increased, and possibly some pleural fluid that's accumulating. The next day, the opacity is not only persistent, but is increased in the left upper lobe. So let me go now to the CT, which in terms of timing was done on the same day, a little bit later in the afternoon. And you'll see there's some pleural fluid up there and a bit of air. But the dominant finding is, of course, is extensive opacity in the left upper lobe. Indeed, the left major fissure is bulging posteriorly, so it's a lobe that is very consolidated, but also expanded with, I'll go to the lung window, opacity. Let me just get this lung window, which is sufficient. It looks like that. But if you look at the background, you can also appreciate there are some septal lines. Of course, anteriorly it's more ground glass somewhat, but mostly consolidated. Now, in this particular context, given the difficult surgery, I went to the medical record and see that they had trouble resecting it and separating it from vessels. I began to examine the vessels because, of course, one is very concerned about an ischemic left upper lobe. And one looks for arteries and veins. Are they patent? Are they narrowed? And certainly I will show you here that we have staples that cut right across lung, and this artery doesn't go very far. And the only vein that I could see coming back was from down here, the lingular division, but I didn't see another vein coming back to left superior pulmonary vein. I also noticed that this bronchus doesn't go very far, and the lingular division is atelectatic as well. So a lot of abnormalities are present, but certainly we do see findings consistent with an ischemic left upper lobe with only a few vessels going to a portion of that left upper lobe, mostly the lingular, but really not beyond that. And I couldn't see a vein, a normal vein coming. So we certainly describe these findings and consistent with ischemic lung, and wondered about what was going on here. Is it a partial torsion, perhaps? It doesn't look very rotated, but this bronchus doesn't get very far before it rat tails down to nothing. So indeed, this turned out to be ischemic lung. They basically completed the upper lobectomy by just basically stapling with staples right across the lung, rather than doing a conventional left upper lobectomy. I think it was just a difficult operation. So that is ischemia. And I couldn't tell from the op report. They described this as partial torsion. I don't know what that is. but they didn't actually otherwise provide findings related to, was it mostly an arterial inflow problem or a venous outflow problem? Perhaps both. Hard to say for sure.
Well, certainly, yeah, the pulmonary artery is just ligated there,
It doesn't go very
like
far.
you
And it's
said.
very close to where the staples are, right? Yep. That's what I was thinking.
Right.
Exactly. So I think just a very difficult operation, and that's what happened. So in pathology, it was benign infarcted lung. And the patient actually did okay in terms of recovering from the second operation and has gone home. But they didn't quite get all the cancer out, I'm afraid. So they'll have to wait and see how that does. But yeah, the complex of finding is very consistent with an ischemic problem. Okay, let me show you this one. I'm going to show you this one completely backwards. So I'm going to start off on a follow-up radiograph after the patient was discharged after being very ill in hospital. And if you were to see this in the outpatient setting, what would you see? So I'm going to show you, and I hope it projects rather nicely, that at this time, there are cystic spaces, thin-walled, in the lung. In fact, many of them, cystic spaces on the left, and going to the right side and looking in the left upper lobe, albeit smaller, but again, many cystic spaces are present, thin-walled, in the lung on the follow-up exam. So let's go back to the month before when he presented ill. So he presented to the ED, having been transferred from another hospital, just being ill. But this radiograph is actually unremarkable. So this is early on the day, and then he got sicker very quickly, so that by 10:30 in the same evening, he looked like that, and he was intubated soon thereafter. Now he looks like that. So now we have extensive multilobar, multifocal consolidation in the lungs that have developed like that in a very short period of time. And now I'll show you the CT done on the 27th, that is the 23rd. Of course, all that time he was very sick in the hospital. And this is what his lungs look like now. So having been admitted apparently with influenza A, it turned out that he then had positive blood cultures for staph. So certainly this is really typical in this context for a severe necrotizing Staphylococcal pneumonia. And we can see cavities of various sizes. Some of these are really even Cheerio-sized foci of cavitation, maybe around airways. It's hard to say, perhaps, but a very, very sick person. But as you can see, he recovered from that, and these left him with those thin-walled cystic spaces on that follow-up exam. So staphylococcal and influenza, and certainly the co-occurrence is well known. I think it said that maybe most of the people in the Spanish flu era died of the staphylococcal pneumonia that they got, and there are all kinds of theories about why you get such severe staphylococcal pneumonia in the context of influenza and influenza epidemics, but this is pretty typical of that.
Wow.
Pretty impressive, huh?
Indeed.
But he's a young guy who recovered from that. That's what he looks like now. All right, I'll show you another one. Actually, this is a nice example of a community-acquired pneumonia. As it turns out, that isn't streptococcus pneumonia or H flu, but this patient presented ill. There's nothing about this other than multifocal multilobar consolidation. That is on the 9th. 2 days later, they did a CT, and there is now rather extensive consolidation in both lungs. Of course, areas of ground glass opacity, but many areas of consolidation, probably some atelectatic lung in the dependent lungs as well. And this turned out by virtue of urinary strep antigen to be ascribed to Legionella. So that's the only positive test that came out for Legionella. So certainly consistent with that imaging-wise.
Mm-hmm.
And she was very sick, but did recover. So by virtue of that, Legionella pneumophila, I don't know where she got it or why, because usually we associate that with contaminated water, or at least some of the time. But Legionella pneumonia, but not in an immunocompromised patient, just the typical pneumophila pneumonia.
Yeah, and that's a very, our ID folks say that that's a very specific test too, the urine antigen for Legionella. So if it's positive, then they have it.
Okay.
Because I think I showed a case a couple months ago where it was a question vaping in the context of Legionella.
Okay. Okay, I'll stop there for the time being, and then.
Yeah, I think it's insensitive though, because they don't rely on it, and it does not react with the other species. So it doesn't react, I think, with McDadii.
Right. Peter, do you have cases?
Yeah, I have two pretty quick ones.
Okay, I'll make you the presenter.
One more point about the Legionella case. If you see a bilateral pneumonia at presentation, it should really push Legionella up in your differential diagnosis, because Legionella is famous for presentation. At presentation, it's already bilateral.
Okay. Yep.
Did they have, Howard, did they have renal or GI issues?
Not that I know of. I'll look to see whether other systems were involved like that. But I didn't find any notation about that.
Can you guys see my screen?
Yes.
Okay. So in the left upper lobe, this is just a adenocarcinoma. But I thought it was interesting just based on its location. It's right behind the costochondral cartilage of the first rib, and it's in front of the vertebral body and behind the trachea. So sometimes I like to retrospectively analyze the radiographs. So I thought this would be a good one for Rader's triangle, or the retrotracheal clear space. Let's take a look at the x-rays.
We were talking about calcifications.
So on the right, we have this one on the left is done right before the CT, and then this one on the right is from years, like 7 or 8 years before that. And then you can see the opacity right here in the retrotracheal clear space. It looks kind of clear on the old radiograph.
How about on the frontal?
Frontal projection?
Yeah, so on the frontal, you could still see it, but no, I think it's easier on the lateral. But if you look closely along the inferior margin of the first rib, you have this opacity that comes off of the rib right there, which, analyzing the first rib on here, you can see how clear you can see the margin of the rib.
But definitely.
So this is one where you could
definitely
Sorry?
in the category of hidden, difficult to see lesions.
Yeah.
Easily gone by, and quite understandably so. Just very often.
Yeah.
Something there.
Yeah. You can see it right there. But yeah, this is just a hard one in retrospect. Show another case. The other case that I have. So looking at this lateral radiograph, there's two hyperdense abnormalities here in the hilum. And if you look they're in the locations of this one, the pulmonary posterior, is in the location of the lateral left pulmonary artery, and then this one is in the location of the right pulmonary artery. So if you look at the PA view,
Can you zoom into that area particularly, because it's very difficult to see?
oh sure,
Zoom in a lot. Now we're getting to see it. Okay.
yeah.
Good.
So they're kind of linear. So if you look at the radiograph, they're basically what you would predict on from the lateral right and left pulmonary arteries. So this is a embolized bone cement from a vertebroplasty, which isn't that uncommon, but I'll just show it.
Will we see it later? Or?
So you have the bone cement, and it's kind of getting into the inferior vena cava. But just wanted to look at these radiographs a little bit closer. Also, I found them interesting. So I thought you could use these embolization, this bone cement that's embolized, served as a good marker for the spatial relationship of a lot of these hilar structures on the lateral radiograph. So if you follow the tracheal column down, the first lucency that you're supposed to see is the right upper lobe bronchus. So you can see that.
Can you zoom in again on the middle image?
Sure. So presumably the trachea is here, and then the first lucency, which you don't see probably on a minority of the radiographs, should be the right upper lobe bronchus, and you can see that immediately posterior to this bone cement, which is in the pulmonary artery. So there's the spatial relationship, and then you can see that on the CT. So you have the cement in the right upper lobe, and immediately posterior to that you have the right upper lobe bronchus, which is the first this round lucency that you can see from a lateral perspective. And then if you follow the airway down, this lucency you should see on almost all radiographs, which is the left main upper lobe continuum. There, and so that corresponds to this, and you can see immediately posterior to that you have the bone cement, which is in the left lower lobar pulmonary artery, which kind of loops right above it. So this is the left lower lobe pulmonary artery, loops right above the airway, and you can see that on the CT right there. So this is actually already in the left lower lobar. And then you can see this hyperdensity in here. The actual airway on the CT looks clear, and it is, but so that is a projection of this laterally embolized cement, which goes right on top, falls right in line with the left main upper lobe continuum, so it projects right over it. And then the posterior wall of the bronchus intermedius here is normal. You can see it there, and then clear infrahilar window. That's about it.
That's interesting. So it must be that the cement is relatively viscous, so that it takes the shape of the first little paraspinal vein that it intravasates into, and even though it subsequently embolizes into bigger vessels, it still retains the relatively small caliber, I guess, of the first venous structure that it entered.
Yeah.
Right. And I was going to say, Peter, there was a case I showed a couple of years ago. There was an older case from here that it was very linear like this, and it was just across the main pulmonary artery, and it actually had been initially interpreted as perhaps a retained wire or a wire fragment rather than embolized methyl methacrylate. So I think it's important to remember, like Howard said, it's probably just due to the viscosity and the first vessel that it gets in, that it casts in that type of shape, and it maintains the shape when it embolizes.
Yeah, yeah.
Yeah. And if you go to your left lateral projection and you go from the material in the right pulmonary artery and you go towards the sternum, I even wonder where there's two little branching things just behind the sternum.
Yeah, the V-shaped thing anteriorly there sure looks like it.
Yeah, it does. It's like the
Yeah,
test,
right
the more
there.
you look, the more you see.
Yeah. It's there's multiple.
Yeah, and you can see those on the PA.
Yeah, there was multiple little areas of embolization.
Yeah.
It was all over the place. So these are all embolized.
Pseudogranulomas, sort of.
Right. Yeah.
None is
Have
quite.
you guys ever seen a case where? Because I had a case recently where I had a really high attenuation. Maybe I'll show it later, but I didn't know what it was. But it was really high attenuation like this in the pulmonary artery, and it didn't show up on the. It wasn't on the. I couldn't see it on the scout or on the scout actually. So I could only see it on the CT. There was no history of any cement kyphoplasty. Have you guys ever seen anything like that? Do you think you should be able to see something that dense on a scout? Maybe I'll show the case some other time.
Okay.
But I didn't know what it was because they never followed up. Basically, I could only see something like a high density material like this, but only on the CT. On the scout of the CT, I didn't see it. So I was confused of what it was.
Was it a contrast enhanced CT?
Yeah, I think so. I'm gonna have to look back.
I showed one case, and I've seen a couple of others from other people where there was contrast that clumped. Because the case I had, they did an arterial and a venous phase, and it looked like it was calcified or ossified or something, and then it was gone on the venous phase. And
yeah,
the theory is just the contrast had clumped and then dissolved.
Yeah, I haven't showed the case just because I was waiting for the patient to follow up so I can actually see what it is. But maybe I'll show it next week because it seems like it's been already a few months. They haven't followed up, so I don't really have a explain. But maybe I'll show it to you guys maybe next week and see what you guys think. Thanks.
All right. Is that it, or do you have more?
No, that's all I have.
Okay. Anybody else? David, you said you don't have any?
Not this week.
I got a couple of quick ones.
Okay. Is that Brian on?
Yeah, this is Brian.
Hey. All right. Let's see if we can make you the presenter. You're using the web.
Okay.
Should get an invite.
Okay, we can.
Yeah, we can see that.
You guys can see my screen?
Yes.
Okay, great. So this is a 24-year-old woman with a prior history of tricuspid valve endocarditis who comes in with recurrent chest pain and fevers. She denied any recent drug use, and all we have is a non-con, but her urine tox screen tested positive for benzodiazepines, and she was bacteremic. So they were worried about septic emboli. But what we can see here are these calcific density filling defects within the right heart. Here we see some in the right atrium in the region of the interatrial septum. These look fairly mobile, and that was confirmed later on echocardiography. Then we also see some extending to the right ventricle here, and then some more here, kind of closer to the tricuspid valve annulus. These are probably stitches related to her prior tricuspid valve repair. And then interestingly, she also has these same calcific density filling defects in the in pulmonary arteries bilaterally, and we can see adjacent to this right lower lobe pulmonary artery filling defect, right upper, we see a right middle lobe infarct, or what looks like an infarct to me. And if you come down here at the left lower lobes, a similar thing where we've got peripheral consolidation and ground glass and a central calcific density within a left lower lobe pulmonary artery. So this hasn't been confirmed yet surgically, but I think this is a case of someone who was crushing up pills, maybe benzos, and then injecting them, and some of the pills reconstituted or clumped within her body and led to this kind of embolic phenomenon with pulmonary infarctions.
Wow.
The next case, this one's a little bit more of a rarity. This is a 34-year-old woman with tuberous sclerosis, and this was a follow-up CT from a CT a year prior to look at some ground glass nodules. We can see some here in the left lower lobe, and then elsewhere. The more you look, the more you start seeing them. No evidence of lymphangiolymatosis. These were all stable from prior. I did a quick literature review, and this entity was one of the things I was reading about: multifocal micronodular pneumocyte hyperplasia. This was one of the original articles from AJR, I think about from 2005. Kind of non-specific findings here, some tiny nodules, but there was a more recent article in PLOS One, which had some CT images as well. And on this one, these looked more similar. You see these ground glass nodules kind of scattered randomly throughout the lungs. So I thought this was possibly a case of that. Yeah, that's it.
Yep, absolutely.
Yep.
Right, because in these patients, I remember one when I was in residency that kept following, thinking that these were adenocarcinomas in situ, and then finally somebody put the two together with the tuberous sclerosis and said, well, they're probably just MMPH, as you just showed.
Interesting, yeah. Maybe they're fairly common, but far too small to see at the resolution we look at. These. They're probably there.
Brian, in that first case that you showed, did you think that those bright clumps were calcified remnants of the tablet, or do you think that was the material from the tablet itself that was so bright?
You mean like additives in the tablet, or?
The tablet's made from the caking material in the tablet, but I've never seen it be bright before. It's my understanding that a lot of these tablets are often they have talc or similar fillers in them to add to the drug material themselves. So I thought that perhaps this might have been some of the filler associated with that. The one differential on this was displacement of her valve itself. The type of valve she has is a tricuspid core matrix. And we weren't able to find a lot in the way of images showing what those look like. But from what I could tell, most of it's relatively radiolucent or isodense to blood pool. And then this material here looked like the stitch ring. This was stable from a CT with contrast 1 year prior, so I thought that was probably related to her core valve. Interestingly, within the same week as her, another young woman with a history of tricuspid valve endocarditis and the same kind of valve came in, and she actually had they opened her up. She had a large saddle PE, and when they opened that up after 2 days of anticoagulation, that saddle PE was actually mostly just valve material that had embolized.
Can you show us the lung windows on this again? Or did she have the more typical little centrilobular nodules?
No, not really.
Excipient lung? No,
not really.
I don't think any of us has ever seen a case in which the tablets and the fragments are so large in vessels that I recall. That's really unusual, if that's what it is.
I wonder if she had embolized.
Weird.
Maybe it's something other than the tablets, or maybe a combination of things. That's very strange.
Yeah.
Yeah, I didn't think it was bright enough to be metallic density. That was my other thought. But here I can show you a prior from a year ago, and this was her a year ago. And
all right, hold on. Let me give you the screen back. Where's my menu?
At the bottom in the middle screen, bottom of the middle.
I think I grabbed it. You guys can see that. Yes, this is her from a year ago, and you come down and you can see right about here. Those are the stitches from the tricuspid valve repair.
Yeah.
But I don't see anything that's definitely calcific density. Certainly no filling defects in the pulmonary arteries. Granted, something that's isodense, maybe it's just hiding there, but there's nothing on here that looked like the lung parenchymal findings. There's some atelectasis, stable lingular atelectasis, but that was it.
Very curious. Oh. Well, we may never know exactly, but that's really interesting.
Yeah, well,
Nice having...
if we get follow up, I think this person may be going to the OR. So if I get any additional info, I'll be sure to share.
Yeah, please. All right. Let's see. This first one's not a diagnostic dilemma on the MRI. This is a man who originally presented with dyspnea, and you can see that there's this large mass that is mobile. It's anchored onto the interatrial septum, and it does prolapse to, maybe not through the mitral valve, but certainly, this is a typical look for a myxoma. There's a little bit of heterogeneous enhancement in it, maybe centrally, just a little bit. So that all fits with myxoma, and I show this A because it's now a path-proven case, but B, this was a few months before the initial workup for dyspnea. He was referred to the pulmonologist here, and so they did a CT. You can see he does not have interstitial lung disease as a cause of his dyspnea. I think we since know why. And I'll just flat out say I was the one that read the CT and called it normal, as I would, 999 times out of 1,000. But if you do look, you can actually see that myxoma there in the left atrium if you window it.
Yeah.
It's not, if it were calcified, that'd be one thing and it'd be easier to see. But I just thought this was fun to show in retrospect that, there is something there. So
only if you know where to look and what to do with your mouse.
what's that?
Only if you know where to look and how to window it.
Yeah, right. What did you say, Howard, on Peter's case? Do you file that under the difficult to see?
I just call them
this is
hidden lesions, difficult to see, retrospective combinations thereof.
Yeah, this is the hidden lesion, impossible to see.
Exactly.
And of course we've shown cases of high attenuation when you see it in the pulmonary arteries with acute pulmonary embolism, that diagnosis can be made on a non-contrast CT. But I thought this was just a fun one to show for this reason.
Travis, can you scroll down a little bit lower on that CT?
Yeah.
Even a little bit lower. I just want to look at the ventricle. Yeah. She must have had a lot of mitral regurgitation, because I could see that left atrial appendage is huge. And
the left atrial appendage is big. I don't know, on the MR, there
the
wasn't a ton of...
large as well.
Yeah, you'll see there's not a lot of mitral regurg. I wonder if it's more inflow issue that was causing, increased left atrial pressures. But you're exactly right. The left atrial appendage is big.
Interesting.
All right. So this one is interesting. And Howard, I'm glad you showed that postoperative case, because this is similar but different. And there's one that I think I showed a couple of you a couple years ago, convinced that a patient had torsion, or at least partial or torsion, where the lung was still viable. So this is a patient who underwent a right upper lobectomy. I didn't include the preoperative CT. Right upper lobe cancer. This is post-op day 1. This is post-op day 2. And you can now see they've developed more opacity medially at the right lung apex. And there's also more volume loss on the right side. He was asymptomatic. They wanted to further evaluate this. And here's, I saw this CT, and you can see this is the right middle lobe, and long airway that then just kind of goes away right there. You can see the vessels, the artery. The arteries do get a little narrowed right at this pedicle, and then the pulmonary vein to the right middle lobe is right here. So it's patent, but it's, there's certainly, this made me nervous. It doesn't have that typical lung parenchymal look of torsion where you get that big, boggy, and congested lobe from impaired venous outflow that just causes it to become congested. There was a little bit of lower attenuation lung right at the tip, and there's a staple line here. And so there was a little, they had to do a little bit of resection of the right middle lobe because the fissure was incomplete. But we, you know, I talked to the surgeon, and he was certainly a little nervous based on this as well. And I said that, you know, I don't know if this is some sort of partial torsion because the lung still looks like it's viable. And interestingly, they went in and did a bronch, and he said that the right middle lobe bronchus was wide open. They were able to get into it, and that he thinks it's just that the lung is collapsed. And this is like the second time I've seen this. He said he's talked to other surgeons who, you know, just colloquially call this just right middle lobe syndrome after right upper lobectomy. And I'm curious what your thoughts are, because here was the follow-up radiograph, and everything to the day of discharge a week later looked just like this. The right middle lobe was still collapsed, but the patient was asymptomatic.
Yeah, I have seen that occasionally where after that kind of surgery, the right middle lobe is atelectatic from the very first post-operative radiograph and doesn't aerate normally. But as you say, the patient's asymptomatic, so maybe that bronchus is stretched, but it doesn't open, but it's not torsed, and the patient is not sick. And sometimes they just the patient, as you said.
How about, Travis, how about a coronal?
Sure. So you can see there's that right middle lobe bronchus, and it just disappears right there. And the vessels do get awfully, you know, awfully thready here. And so, and especially these pulmonary veins. And that's why I said I was worried about some sort of, you know, like, you know, for lack of a better term, like partial or incomplete torsion where the lung is still viable,
right,
you know, as a cause for why this airway, you know, and why the lung is collapsed. But
and as you scroll back,
he was saying that, yeah,
you can see the tubular fluid-filled bronchi adjacent to the vessels. So the bronchi contain secretions or fluid that's not coming out, as in atelectatic lung. So maybe that bronchus is just narrowed, it's stretched and so narrowed that that in combination with secretions results in this situation. Something like that.
Yeah, because it's, I mean, it's certainly one where you have conflicting findings, because like I said, it doesn't look like a torsed lobe in the sense that it's not infarcted and edematous and, you know, congested like we see.
Yeah, exactly.
So, yeah, but I'll have to try and find the other one that I saw that looks similar to this. But he was saying that this is, that other surgeons he had talked to, you know, have seen this as well. And he was pretty adamant that he was doubtful this was torsed either, because he had done a lobectomy to the right middle or right lower lobe, you know, like they do to prevent torsion.
Yeah.
All right, this is one that just came in, and I will appreciate anyone's thoughts. 44-year-old woman, and this is from the general. You can see right off the bat, it's interesting, there's volume loss on this side, and you see this mass here, but also notice the lung is loosened relative to the right lung. So it's kind of volume loss with decreased vascular markings on that side. This is the CT, the first CT that she got. And right off the bat, you can see that she has undoubtedly pulmonary hypertension, dilated right ventricle hypertrophy, and probably has some congestive hepatopathy as a result of her right heart issues. She's got a little bit of ascites and a heterogeneously looking liver. And this mass is interesting here, or this thing in the hilum, because the first person that looked at this, they were thinking maybe this was blush in contrast, but I think this is actually, well, I know it's actually just calcification, because there was a follow-up that was done with a venous phase, and you can see that on the venous phase, this still is similar attenuation, and if we window these the same. So it's like in the 300 Hounsfield unit range. So it's this calcified thing, and it's resulting in obstruction of the right or the left upper lobe bronchus. You know, the arteries are occluded, which I think accounts for the hyperlucency. The veins, maybe narrowed to some degree as well. So they were, this was shown to me as what type of tumor do I think this is? I'm actually not convinced this is a tumor, and I'm curious what you guys think. If you think this could be just a really aggressive form of a fibrosing hyalitis, especially given the other findings, and there's some little calcified nodes here as well.
Anything in this?
I wish Jeff were on here because he sees this more than anyone. But what do you guys think?
Anything in the spleen?
No, I looked at the spleen. I don't think we can slam dunk this as a histo. I mean, it certainly is weird, but that calcified portion there, and the fact that there's just really bad pulmonary hypertension, this has probably been there for quite a while.
And
we don't think this thing is in the airway. This isn't. It's just leaning away, right?
Yeah, David, I don't think so. Right, because a carcinoid certainly could be calcified. I think it's just impinging on the airway. If you see here, that left upper lobe bronchus, that it gets narrowed here, and there is some obstruction, but in the lingula in particular. But yeah,
and it's a calcified portion of a larger mass.
right. With some other little calcified nodes right here. She doesn't have a history of like a mucinous colon cancer or something. So she's fairly young. I mean, obviously, I think they're going to have to work this up further, and maybe it will end up that there's some weird mass underneath that. But
I'm just wondering if it's a hematoma or a carcinoid with some calcification, but not uniformly calcified.
I was just wondering if, just given the degree of all the mass effect on the vessels and everything else in the rest of the left lung, that it is.
Yeah, Travis, I think it's more of a mass than it is a lymph node, calcification, a la, hyalitis. I think this is probably a tumor. And I first wondered whether it was actually something. Could it be something in the pulmonary artery? Could it be, say, a calcified thrombus in the pulmonary artery? But I think it's adjacent, not in the pulmonary artery.
Yeah. Right, because you can see it's just.
Or just
what'd you say?
Is it affecting narrowing pulmonary veins, or just because the artery looks definitely narrow there?
The veins are patent. They're diminutive. Maybe this node here next to that vein.
There's not much.
I don't know, David. I mean,
in the lungs, really.
Oh, that pulmonary artery is empty.
Pulmonary artery is narrow.
It's being leaned on. Yeah, I think this is some sort of tumor, I think.
Certainly that's the first thing, and then the fibrosing hyalitis would be a diagnosis of exclusion. I just wondered if
I'd like to see more.
If we had seen
elsewhere, right?
Yeah, this degree. So, all right. Well, I'll keep this one on the follow-up list and hopefully get something from it. All right, and then one more. This is just a quick one. Another young patient who we saw in 2018, 2019. And, I think that you usually go with the rules when you're dealing with subsolid nodules, right? That focal fibrosis, usually less than 5 millimeters, adenocarcinoma or atypical adenomatous hyperplasia, maybe up to 1 centimeter. Then you start getting into adenocarcinoma in situ, and certainly if you see a little bit of soft tissue. So this was originally, this lady was seen for either trauma or chest pain. I don't remember what, but this was an incidentaloma. She was told that this was very likely to be cancer. She's young. This was a follow-up. No, that's the same date. This was the follow-up, or this was the original one from a year before. And you can see this was the time of presentation. It's virtually identical. And we've seen other people have shown cases similar to this, that I think it's just a reminder. If I can turn off the sync. You can see it hasn't really changed, but based on the fact that it could be cancer, she wanted it taken out. This did turn out to be, the way they interpreted it was they actually combined both lymphoid hyperplasia and some fibrosis. So just chronic inflammation and lymphoid hyperplasia. So I'm not exactly sure, if you'd say it's focal fibrosis or lymphoid hyperplasia or a combination of two, but I think it's just a reminder that things larger than 5 millimeters or even a centimeter can be benign in a minority of patients. So it's important, to think about even in these kind of cases. So I think that's all I've got. Anyone else?
I can show a quick companion to your myxoma case.
Sure.
So it's another non-con chest CT. They think this one's a little bit less of an eye test, but a normal soft tissue window is a little bit hard to see. But if you window it in kind of the right way, you start seeing this hypodense mass in the left atrium, and this was confirmed to be a large myxoma with organizing thrombus on path.
And this patient has some heart failure, right? They've got effusions and
that was why they came in actually.
Yeah, that's cool. That's a huge one.
I can show two more, Travis, to take up 10 minutes here.
Should have an invite. There you go.
So I did not see this patient in the context of our multidisciplinary ILD conference, which we do have. As best I can tell, they just sent the patient to the surgeon for a surgical biopsy for ILD. And in looking at the radiograph, it's quite unremarkable in terms of the overall extent of disease, because that's really just located up in the apical lungs. So there are subsegmental sized opacities. They go up to the apex, but they also involve the lateral portion of the lung apices. There's a little mild degree of volume loss associated with that. And of course, the CT is going to look just as you might expect, abnormal, but relatively sparse abnormality. So definitely apical lateral, a modest amount of upper lobe volume loss, but that's it. So here is the lung biopsy result, which is, as one would kind of expect, that this is a case of pleuroparenchymal fibroelastosis. But why this person has it, I don't know. So apparently she worked as a geologist for 15 years. I don't have more details about the exposure in the terms of the underground and surface mining as a geologist. So I don't know how much she inhaled. Certainly she doesn't have findings of silicosis or co-workers pneumoconiosis. And there is no history in the medical record of a family, because usually I think transplantation is the usual association, lung transplantation, stem cell transplantation, family history, and then idiopathic or sporadic pleuroparenchymal fibroelastosis. But certainly the distribution is consistent with what we see, but it doesn't seem that too severe to me in terms of the extent of it. So I do have that path correlation.
Yeah.
I don't know what to do otherwise.
Yeah, this kind of raises the question, where do you draw the line between just apical fibrous cap and symptomatic pleuroparenchymal fibroelastosis? Because we've talked with our pulmonary pathologist here, and it's essentially the same histology. It's just the severity.
Yeah. I don't know. Obviously, this is more than just an apical cap. What we would describe as an apical cap, there's a little more there, and it goes away from the apices a little, but not too severe. So I'm not sure exactly what to learn about this case, other than that's the histology. It's curious. Here is a person with radiograph, which was post-operative, looking like this. And of course, it's really helpful to have the context because it's the combination of knowing the patient is post-operative, noticing the elevation of the diaphragm, which is new, and then if you're lucky, you can appreciate there's too much opacity there. Then you look at the medical record, and indeed, she is a post-operative patient that had surgery in the right supraclavicular region. It turned out that she had surgery for a stenosis of the origin of the subclavian vein, and they elected to do a transposition procedure. So they transposed subclavian artery to carotid up here, but you can see there is a fair amount of blood and hematoma at the operative site. So in spite of taking great care to try to avoid injury to the phrenic nerve, undoubtedly there's still some phrenic nerve injury. So time will tell whether it's a neuropraxia, something the patient will recover from, but certainly I'm finding it's very consistent with a phrenic nerve injury in the context of the vascular surgery. And that does happen, of course. That's what it looks like. All right, those are my cases. Travis?
Thanks, everyone.
All right, thanks everyone. See you next
Thank you.
week.
Thank you. Thanks, everyone.
Bye-bye.
Bye now.